Now I'm going to talk a little bit about skin infections, and I'll start with bacterial infections. So impetigo is a common bacterial skin infection. It's usually due to Staphylococcus aureus, but it can be due to beta hemolytic streptococcus such as strep pyogenes. You can get pustules, and then you often get these classic honeycomb coloured crusted erosions. You can get a subtype of impetigo called bullous impetigo, in which you get blisters, and this often occurs due to the staphylococcal exfoliative toxins. Treatment for this would just simply be local antibiotics if it's not too severe, such as mupirocin, and if it was more severe or if the patient was unwell, you'd consider giving oral flucloxacillin. So erysipelas it's a more superficial form of cellulitis. And unlike cellulitis, almost all cases are caused by group A beta hemolytic strep. And you get these distinctive warm red tender lesions with induration as seen here, and oftentimes they can get blistering within these lesions. The borders tend to be very well demarcated, and it is very tender. As I mentioned, vesicles or bullae can develop. The legs tend to be the commonest area affected, but it also frequently affects the face. The patient will often have raised white cell count, and blood cultures will be positive in about 5% of patients. Usually, you need to treat with IV antibiotics if they're unwell, so you could consider benzylpenicillin and erythromycin or whatever the local guidelines are. So differential diagnosis, I suppose, if it's in the leg and it's red, indurated and angry looking, you need to think about a DVT, you need to think about necrotizing fasciitis, and you need to think about a contact dermatitis, whether it be irritant or allergic. Now, the infection can cause damage to the surrounding lymphatics, and this will leave the patient prone to lymphedema, and it will also leave them prone to recurrence of the infection. So here's a case of one lady. Now, usually it is unilateral, and this is actually quite rare where it is bilateral. And here's another case in which we can see more how red and angry looking it is, and we can also see a bit of blistering as well. So we'll now move on to fungal infections. So we'll first talk about dermatophytes, and the diagnosis is made by microscopy of scrapings taken from the lesions. So you just basically get a little blade and you scrape away some of the scale from the lesion, and that will usually be enough to make the diagnosis. So clinically, you get these erythematous plaques with a scaling border and an area of healing in the center. So here's a picture of tinea cruris, and you often get this advancing scale. You get this advancing edge, and you get a trailing scale just slightly inside of it, and then usually there's a bit of clearing more in the center. So any infection with dermatophyte is called tinea. And then the name that it gets after that depends on the location of where the infection is. And this is irregardless of the type of microorganism causing it. So, for instance, tinea corporis means infection affecting the body. Tinea pedis means infection affecting the feet. Tinea cruris is affecting the groin. And here's a picture of that there. This tends to be more common in men and also during the hot and humid seasons. And this can extend to the inner thighs and backwards to the perineum and anus. And oftentimes this infection can actually spread from the toe webs up to the groin. Tinea manum is then where you can get a dry and scaly form of the infection of the hand, and it often only affects one hand, and it often is transferred again from the feet, so the feet should always be examined. And then moving on to the feet, tinea pedis. So this is the commonest fungal infection, also called athlete's foot, and the primary lesion consists of kind of maceration, scaling. You can sometimes get little vesicles or deep fissures between and underneath the toes, and any or all of the toe webs may be affected. And for some reason, the commonest toe web affected is the foot. And then, if this infection gets into the nails, you can get onychomycosis, which is a tinea infection of the nails. And this accounts for about 30% of all superficial infections. And you often get these discolored, soft, brittle nail plates, which then move away from the nail bed. And the commonest form starts distally in the nail plate. And here's a good image because it shows tinea pedis and also onychomycosis. diagnosis. To get the diagnosis here, you would just basically take some nail clippings. So I think this question comes up a bit in the exam, tinea incognito. So this is the name given to a tinea infection when the appearance has been altered by inappropriate treatment. So sometimes, oftentimes in dermatology or in GP practices, we often give a steroid cream for pretty much anything. And now usually it's effective. However, if it is a fungal infection, it will initially mask the fungal infection, and the original infection will then slowly extend. And then once you stop the steroid, after a few days, the rash will come back with a vengeance, and it will have an altered appearance. You'll often see, you can't really see it here, but you'll often see, you'll often develop pustules within this rash, and it can look unusual with no distinct pattern as seen here. Now, another area that tinea can affect is the head, and this is called tinea capitis. And this can be due to a number of different organisms: Trichophyton tonsurans, M. canis, T. rubrum, or T. verrucosum can all affect this area. Just one note: M. canis is zoophilic, and this means it's derived from animals. So you can, canis, canine. And oftentimes, if it's derived from animals, it's often more severe than if it was derived from humans. And here's an image of tinea capitis, in which you get, now it's not a great image, but you get kind of a red scaly lesion, and it can be quite itchy. Here is a thing called carrion, which happens when you get a severe fungal infection, and you can get this boggy swelling that can be, it can look quite unsightly, and it can be quite painful. And importantly, this can lead to a scarring alopecia also. Then I really haven't heard about this, but it came up in some of the MCQs. Favus. This is a type of tinea capitis. It's rare in the UK and USA, but you can get it in the Middle East, Southeast Europe, and the Mediterranean. And you get these cup-shaped crusts called scutula, which form around loose hairs. And the lesion may resemble a cradle cap, and scarring alopecia is common. And this is due to Trichophyton schonleni. And when the lesion falls off, the portion of the scalp affected is usually hairless. I wouldn't really bother too much about Favus, to tell the truth. So to diagnose tinea, you need scrapings, and you stain them in potassium hydroxide. With regards to management, you can use a topical preparation such as miconazole, which is also known as Dactarin, or ketoconazole. And then if it's more severe, you might need to go on to oral antifungals such as itraconazole. Now, you often need prolonged treatment. So if it's body or scalp lesions, you'll probably need about 4 to 6 weeks or even longer. And then if it's a nail infection, you really need a really long course, up to about 6 months. And even then, it mightn't be that effective. So, Candida infection refers to infection due to a group of yeasts. This infection particularly occurs in moist areas, such as flexural areas like the groin and under the breast, and it's also commonly seen in under occluded surfaces. So it's often seen in infants with nappy rash. The classic sign of it is you get these satellite lesions which extend beyond the main rash itself, and this tends to be much more commonly seen in immunosuppressed patients, so people with diabetes, HIV, steroids, etc. And you can also get an oral candida, and you can get vaginal candida or thrush. And basically, you can just treat this usually with topical antifungals. We'll now move on to viral infections, and I'll start with the herpes family of viruses. I'll talk about herpes simplex virus type 1 and type 2 first. They often present with localized vesicles and blistering that can then break down and form these erosions. And obviously the colloquial name for these are cold sores. And oral involvement is more frequently due to herpes simplex virus 1, whereas genital involvement is more frequently due to herpes simplex virus 2, but there is crossover between the two. So genital ulcers. So herpetic ulcers are the commonest cause of genital ulceration in the developed world, and 80% are caused by herpes simplex virus 2, and only 20% by herpes simplex virus 1. And the ones caused by herpes simplex virus 2 tend to be more severe and more painful. And as I said, the primary lesions can be quite painful, and they're often associated with enlarged lymph nodes. And you'd usually just treat these with an oral antiviral, such as acyclovir or valcyclovir. Now, eczema herpeticum is a medical emergency, and it is seen in patients who have atopic eczema. And because of their condition, they're prone to getting infections with herpes simplex virus, and the virus is able to be disseminated throughout this eczematous area. So it can be quite widespread, and the patient can be quite unwell with this. If it affects in or around the eye, there is a risk of the patient going blind, so they need to be reviewed by ophthalmology pretty urgently. And you'll usually give treatment with acyclovir, and they often have secondary bacterial infections, so they'll often need antibiotics as well. Um, you should suspect this in a patient that has a severe flare of eczema, and then the kind of presenting sign, which I'm not sure if you can really see it too well, but you often get these punched out lesions, and that's kind of the telltale sign that they're infected with herpes simplex as well. So varicella, chickenpox, we not usually dealt with really in a dermatology office. It's often usually picked up by the GP, but the rash is often distributed centripetally. So the trunk tends to be affected more than the extremities, although this image wouldn't be in keeping with that. But the thing about chickenpox is that individual lesions are in various stages of development. So some areas you might just get simple macules, some areas you get raised papules, and in some areas you can get these vesicles. Which you can't really see any intact vesicles there, which can then crust off and leave erosions, and then once they're crusted over, they then get healed over time. So chickenpox in adults is much more serious than in children. You can get a pneumonia in about 20% of adults, occurring about 3 to 5 days into the course of illness. So if an adult has chickenpox, you need to look out for the classic symptoms of pneumonia, such as tachypnea, cough, dyspnea, and fever. They can also get cyanosis, pleuritic chest pain, and hemoptysis. And you'll probably need to treat them with IV antivirals, such as acyclovir, in these cases. Varicella zoster or shingles is more commonly in the elderly and immunosuppressed. It is caused by the activation of the dormant virus, which has been living in the dorsal root ganglion nerve cells in the spine after prior exposure to varicella in the past. When reactivated, it then migrates down the sensory nerve to cause herpes zoster lesions in the skin. And you often get a pain preceding the characteristic vesicular lesions. So here's kind of a classic rash that we see. You often get these vesicles or blisters, and it's often in a dermatomal region. So it usually just one dermatome is affected. However, it can affect multiple dermatomes, and it can be quite widespread. So you need to be aware of that. It also tends to not cross the midline, but again, it can on occasion. So just with regards to kind of special cases of zoster, so you can get a postherpetic neuralgia, and this can persist for years after the initial rash, and the treatment can be very challenging. Patients may require, types of antidepressants or carbamazepine, or in some cases you can even consider ablation of the affected ganglion. Then there's a thing called Ramsay-Hunt syndrome, this is where you get reactivation of the zoster virus in the geniculate ganglion, and this is a collection of sensory neurons of the facial nerve, and so this can result in pain and vesicles in the ears. It can cause an ipsilateral facial palsy, and it can also cause sometimes the impairment of taste on the same side. If the ophthalmic branch of the trigeminal nerve is affected, it can lead to corneal ulcers and blindness. And just in general, with regards to herpes infection of the eye, it often affects the cornea, and this is called keratitis. And this can lead to corneal ulcers, and they're called dendritic ulcers, which basically means they look like they're branching out when you look at them with the special staining. The recurrences are common of eye infections, and they can result in blindness. Just with regards to treatment of zoster, if it's quite severe, they might need oral or IV antivirals. Um, Now, this isn't the best image, but this is a thing called herpetic whitlow. It's what it used to be commonly seen in dentists and other health workers before the universal use of gloves, and now it's seen more commonly in children. And it was basically because the dentists were kind of fiddling with their fingers around the mouth and picking it up, and you can get pain and vesicles or blistering, which can be seen on the pulp of the fingers, and it also can be seen around the nail fold, and it can be quite painful when you get tenderness, erythema, and deep-seated blisters around the nail fold. And as said, this is probably not the best image. Molluscum contagiosum is very common, and it's often seen in childhood, and it's caused by the DNA pox virus called Molluscum contagiosum virus, and it often presents with these umbilicated pearly papules, which are about 2 to 5 millimeters in diameter. They can be quite widespread, and they often occur on the face, especially near the eyelids, but also on the genitals and trunk. Oftentimes, I've written here treat with cryotherapy or curettage, but oftentimes you just reassure the parents in most cases, and it will often go after about 12 to 18 months. It can be spread through water, so if people are sharing baths or anything, it can be spread through that. It can be more widespread in patients with advanced HIV and AIDS, and it can be quite severe in these cases. So moving on to syphilis. So the first lesion we usually see, which is soon after the patient gets the infection, is a chancre, and this is a small, firm, and painless ulcer. And you often get lymphadenopathy close by, so you might get it in the inguinal area. And then this often goes away, and yeah, then you can get the manifestations of secondary syphilis, and this often develops about 4 to 12 weeks after the primary infection. And it's characterized, the most usual characterization is this macular and papular rash, which is symmetrical, and it can be found on the trunk and limbs. And importantly, to differentiate it from things such as guttate psoriasis or pityriasis rosea, which we'll talk about later, it is often seen on the palms and soles. Now, I apologize for the poor image, but this rash is quite similar to the rash seen on this area here. You can also get these confluent kind of grey, slate grey plaques that are kind of wart-like lesions and can be quite unsightly at times. They often form in these moist flexural areas such as the groin and around the buttocks, and the name of these are condyloma lata. And here is a particularly florid case of the condyloma lata here in the buttocks area. And also patients can get, which unfortunately I don't have an image of here, but they can get small grey or white erosions which are seen on the buccal mucosa, and they often look like the tracks that are left after a snail has gone by, and they're called snail track ulcers often. And patient can be unwell enough, they can get muscle and joint pains, headaches and fevers in this secondary phase of syphilis, and generalized lymphadenopathy is quite common as well at this stage. And so I'll now move on to chancroid. And this is the commonest cause of genital ulcers in Africa. It often occurs 4 to 7 days after incubation. And the organism responsible for this is Haemophilus ducreyi. And you often get an initial erythematous papule, which then breaks down into this painful ulcer. And oftentimes you can get several ulcers that merge together to form really large lesions. The commonest site you see them is kind of on the prepuce and the frenulum of the penis, and you can get them in the vaginal entrance and perineum in women. And you can often get this enlarged unilateral lymphadenopathy in the inguinal area, and this can leak pus as well sometimes. And you make it to diagnosis by taking swabs of the and or isolating it on chocolate-based media, and treatment is with cotrimoxazole or tetracycline antibiotic. I'll now move on to different tumors that we see in dermatology. So I'll first of all talk about the squamous cell spectrum, squamous cell carcinoma spectrum, and usually starts as a premalignant lesion, which is called actinokeratosis, also known as solar keratosis. Then moving on to squamous cell carcinoma in situ, which is also called Bowen's disease, and then you get the invasive form of squamous cell carcinoma. So here are some images of the pre-malignant type, which is actinic keratosis. This basically means you just have some atypical keratinocytes seen in the epidermis of the skin, and you often get these scaly erythematous areas, which can be quite widespread, as seen here. And we'd often just say this person has very sun-damaged skin, where you get this pink base and kind of adherent scale on top. These are common sites: the forehead and the dorsum of the hands. And you can treat these with cryotherapy, or there are different types of creams which can cause an immune response in the skin and get rid of these actinic keratoses. Then, if the atypical keratinocytes make up most of the layers of the epidermis, it's called squamous cell carcinoma in situ, and the other name for this is Bowen's disease. And you often see these thicker plaques as seen here, and the common area we see these in are the legs of elderly patients. And then once the atypical cells kind of get through the basement membrane and invade into the dermis, we then have invasive squamous cell carcinoma. A tip that it's invasive is that you'll feel around the lesion, and it will be tender, and there'll also be induration, which you can feel under the skin. Now, these are very extreme cases of squamous cell carcinoma, so I hope most people will note that something's is wrong is going on here. This is kind of a fungating lesion which is seen on the temple of this patient. You can actually see he's got a bit of sun damage elsewhere, and then this is a kind of nodular squamous cell carcinoma affecting the lip. So I'll just talk a bit about squamous cell carcinoma now. So as I mentioned, it's a malignancy of the keratinocytes, which are the most common cells seen in the epidermis of the skin. It's usually a disease of the elderly, and often occurs in sun-exposed areas such as the face, the lower lips, the dorsum of the hands, and it's the second most common type of non-melanoma skin cancer after basal cell carcinoma. On exam, as mentioned, it's often tender and indurated, and then it can spread to distant sites through lymphatic channels. And the risk of metastasis really depends on its size. So obviously the bigger the more risk, and also the location. So just important to note that the ears and the lips are kind of the areas of highest risk of metastasis. Can get a diagnosis through biopsy, and then treatment is usually surgery to excise the lesion, and some cases radiotherapy is indicated also. And there's prognosis is okay, a 5-year survival of 73% usually. But this depends really on how big the lesion is and where it's found. Now, another thing which is quite like squamous cell carcinoma, but I actually wouldn't really classify it as a malignancy, despite what I say here. It's called a keratoacanthoma, and it's usually seen on sun-exposed sites, and it's developed from the hair follicle, and it's more common in males, and it can look like a squamous cell carcinoma. It often presents as a fleshy, elevated nodular lesion, and you usually get this central hyperkeratotic core. And the most significant feature is that it's got a striking and rapid growth pattern. So it often grows really quickly over a number of weeks, and then over time it actually usually involutes and goes back to normal. The short history and rapid increase in size suggests a keratoacanthoma rather than an SEC, but obviously you need to be careful, and probably if you saw something like this, unless you're very confident, you often would remove it. The good news about it is it doesn't tend to spread elsewhere. So I'll now move on to basal cell carcinomas, and this is the commonest cutaneous neoplasm in humans, and 85% are found on the head and neck. And of course, the major risk factor is sun exposure. So nodular basal cell carcinoma, this is the commonest facial BCC we see, and you often get this kind of raised border, which looks pretty white, and the border might even look a bit kind of translucent. And you often see these prominent telangiectasia as well. It might be difficult to see here, but you can kind of see telangiectasia there and there as well. And you often get central ulceration as well. This is quite a large BCC, and this has probably grown over a long period of time. And then the other major type we see is superficial BCC. And this tends to occur more frequently on the trunk and extremities, and it presents with kind of scaling, irregular, usually pink plaque. And again, if you look closely, which you mightn't be able to see here, you often have a pearly white raised border. Now, there's a very sneaky type of basal cell carcinoma called morphic or sclerosing basal cell carcinoma. And oftentimes you might just get this small lesion that looks quite, it might look like a BCC, but it will look quite small. But as you can see, as this doctor is doing, they're spreading the skin tight. And you can see this kind of waxy pale area around it. And that's all basal cell carcinoma. And it can get quite wide and quite deep subclinical extension. So oftentimes it can be really spread, really infiltrated quite deep and far, and you might need to do quite a large excision. Thankfully, it's rare enough compared to the other basal cell carcinomas. And with regards to treatment, with regards to prognosis, it is exceedingly rare for the basal cell carcinoma to spread elsewhere, although it has been reported to do this in the past. But the major thing is that it's a rodent ulcer, which basically means it's kind of infiltrates away slowly and slowly in its local area. So if you don't remove it, it will just infiltrate further and further in its local area. So for large and deep tumors, you often excise it. So really for nodular component and morphic BCCs, you'll need to fully excise it. Whereas for superficial BCCs, you can consider cryotherapy, or you can consider certain topical agents which create an immune response against the tumor cells, or you can even use photodynamic light therapy against it. They have a high cure rate, and as mentioned previously, morphiform BCCs are quite difficult to manage due to their far extension, so they tend to have the highest recurrence. Now I'll move on to melanoma, which is a malignancy of melanocytes. And melanocytes are the cells often found in the basal layer of the epidermis that produce pigment, melanin. And regards to the criteria for diagnosis, you often have the A, B, C, D, E criteria. So you look for asymmetry, as kind of seen here. You look for an irregular border. You look for variability in color, as we can see here again. And diameter is criteria of greater than 5 millimeters, which might point to it being a pigmented lesion being melanoma, but it can be smaller than 5 millimeters as well. And evolving, so if the lesion is kind of changing over time, that's another concern. Other things are bleeding, itching, and if you get little satellite lesions, which can be found away from the primary lesion. So very importantly, you always want to do an excision biopsy when you want to get the diagnosis of melanoma. And the major determining prognostic factor is how thick this melanoma is extending down into the dermis, and this is called Breslow's thickness. Now I say that excision biopsy is important because if you were to take a biopsy in one area here, you might actually miss where the melanocytes invade down into the dermis, and you might miss the diagnosis of melanoma, which is very risky, of course. So here's a picture of one subtype of melanoma, which is a superficial spreading melanoma. So it tends to be spreading outwards more quicker than downwards and deep into the skin. Another common variant is nodular melanoma, and as you can see here, we've got a raised pigmented lesion which will be invading probably quite deep into the skin. And you often get varying colors in melanoma, so you can get the black, you can get grey, you can get blue, and you can even get pink. In fact, you can sometimes get no pigment whatsoever, and this is a nodular melanoma that we say is amelanotic, so there's no pigment in these cancer cells. Another variant we often see, well, it's actually quite rare to see, is acral lentiginous melanoma. And this is just melanoma affecting the acral area, such as the soles of the feet and the palms of the hands. And this actually, even though this is a Caucasian patient, we often see this in darkly skinned races. And it's often got a poor prognosis, and this may in part be due to the fact that people often miss a pigmented lesion on the soles of their feet. You can also get melanoma affecting the nail, and it often arises from the nail matrix, which is kind of around this area under the proximal nail fold. and you often get these varied pigmented lines that vary in color and extend out to the distal nail plate. One sign for nail melanoma is a thing called Hutchinson's nail sign, and you can see that the pigment not only is on the nail plate, but it's gone more proximally onto the proximal nail fold, and this is a pointer to malignant melanoma. You can also get benign nevi or benign moles in the nail as well. However, the pigment will often be much more uniform and you won't see this varied color in it. Now talk about lentigo maligna, and this is kind of a subtype of melanoma in situ that is often seen on the face. So patients often get a dark brown patch seen on the face as here. And it's a type of malignant melanoma in situ, which means it hasn't invaded down into the dermis. It often occurs on facial or sun-exposed skin of patients in their 60s or older. And it can often be very slow growing, so it can spread outwards over years and decades. But it does have the potential to invade into the dermis, and then this lentigo maligna is called a lentigo maligna melanoma, and it kind of behaves just like any melanoma at this point. And you might suspect that it's invaded if the lesion gets thicker in any area, or if you get these discrete nodules, or if it gets darker. So I'd actually be concerned enough that these dark areas here might represent invasion into the dermis. So you might want to do a biopsy of these areas.